Hello and welcome. We'll be starting in about 2 minutes with you all. We are so glad that you joined us today to talk about COVID-19 and infection control and environmental disinfection. We'll be starting in 2 minutes, and I am so proud of Loretta and Jennifer. Thank you for putting your name and affiliation in the chat. Good work. Yay! So if you haven't yet, please put your name and affiliation in the chat, and you'll see our reminders on housekeeping on this screen. We're so glad you joined us again. Hello and welcome to session 5 of our COVID infection control series here at the University of Louisville in partnership with the Kentucky Nurses Association. So just quick little housekeeping reminders. Please place your name and affiliation in the chat so we get to know you. If you have a camera, please turn it on. We love to see your smiling faces. If you can, we know people are in situations where they cannot or do not have a camera. To ask a question, you can unmute yourself, and the easiest way to do this is hold down your spacebar and then release it, kind of like a walkie-talkie mode. Or if you are calling in on the phone, it would be *6, and then you would press *6 again to mute yourself. We will not discuss any PHI, so any names or any resemblance of a person is totally made up. If you are not comfortable vocalizing your question, you can always place it in the chat. We are happy to answer it that way. You can stop us and ask a question as well. And then if we ever do run out of time to answer those questions, we will send out an email with the responses to the questions. And with that, I will hand this over to Delanor from the Kentucky Nurses Association. Oops, are you
Unmute Delener, or can I hear you?
There you go.
All right. Hello, everyone. Welcome to this edition of the series of education for nurses by nurses. In this year of the nurse, I think it's exceptionally important for us to have answers for our colleagues, family, and friends. Also want to say that the Kentucky Nurses Association is still busy with its outreach in this year of the nurse. And I think we have people joining us from all over the country. We really appreciate that. And so with that, I say welcome again. And I look forward to this exciting program, as they all have been. Hi, everybody.
Delener, thank you very much, because as we know, this is the year of the nurse, and we frequently say it at K&A, at board meetings and other meetings that, wow, what a year. And so this wasn't what we envisioned, but this is what we have, and we're putting in the activities of nurses forward and pushing forward, because again, this is who the public trusts. And so part of our relationship with the general public is to do our best work, not only one day, but every day. And COVID-19 is giving us an opportunity to demonstrate this. So thank you, Delener, for continuing to be a partner in this initiative, and we look forward to this continuing. So I'm always thankful for Kim Buckner, that is our operations and lead for all of our activities with Project ECHO. I'm also joined by my colleague, Dr. Dawn Balcom, that is part of this process. And I wanted to start off, one of the questions that we had last time with the session is that, hey, you guys, what about wearing masks during these sessions? So I thought it would be a good time just to kind of share what our approach is in infectious diseases. First of all, it's we realize that masks or face cloths, face protections, are a very important component, as is social distancing, hand hygiene, and environmental disinfection. Our job is to figure out the balance and also recognize risk and benefit. So we talked a little bit about PPE in the past, and we talked about one of the challenges that we have with wearing any type of something that goes across our face. Our natural inclination is to touch and to move. And I wish I had a nickel for every time I walk down the hall of a facility and I see somebody holding their respirator out in front of them just so they can get some air. So in infectious diseases, we have a very comprehensive approach to monitoring personnel. So every day when we get up, we get an email that we report back our temperature. Everybody was given a thermometer. We all report our temperature, symptoms, and anything out of the ordinary, and that is monitored every day. We also are tested, so we can then determine what is present. In the event anyone is ill, then they are evaluated and to determine if there is a necessity for additional testing. And then when we are in settings, then of course we all have a variety of pieces of respiratory protection, masks and respirators and so forth. So I think this is representative of the challenges that we will see as we begin to bring students back and as we continue to figure out what life in the time of COVID means with respect to PPE. So with that, I want to move on, and I always love the cartoons that Kim puts together, that here's somebody in infection control that says, you know, I should have said, I'm not afraid of hard work, rather than I don't mind getting my hands dirty. You know, dirty hands then is a bad phrase, right? The bad word in infection control. So I appreciate that bit of humor. So as we get started, none of us have any disclosures to report relevant to this particular activity, and that I've used a variety of products as examples to bring out then some of the discussion points. So none of these mean that, you know, I feel like this product is necessarily better than that product. It's just to be able to get the point across, and just demonstrates the variety of products that are available for infection prevention and control when we are looking at the environment. So if you have questions about any of those, or you may have a number of different products that you use, and it's good then to hear back about your experiences. One of the things that I've noticed right now is that it has always been very difficult for us in any healthcare setting to have easy access to our industry partners. And if you're like me, one of the ways I learn about what is new is from industry, that I want to see what new products and services are available. How do I get information? How do I ask questions? So that interactive approach with industry. So that is not as available to us now. It may continue to be more restrictive, both due to just the interactions as well as the possibilities with transmission. But I think we're going to have to figure out ways where we can see different types of products and actually understand their relevance, both from an academic setting that we may be using to teach in our simulation centers or in our classrooms, as well as what we're going to use in the practice setting. So I wanted to bring forward that if you see a product, it doesn't mean that I love it. It just means it's something I'm using as an example. So today we're going to talk about some of the different cleaning approaches, specifically around this SARS-CoV-2. We're going to look at some supplies and equipment, and then we're going to think about some of the strategies that may be helpful for us as we are trying to figure out, what's next as we look at improvement. So just some basics about this virus. We know that the SARS-CoV-2, or that SARS coronavirus 2 virus, is an enveloped virus. So those, as compared with non-enveloped viruses, those are a little bit easier to kill. So we know that SARS-CoV-2, just like the other coronaviruses and other pathogens that we see in the healthcare setting, if we are using the hospital grade or healthcare grade EPA approved or EPA registered germicides, then these should be effective. But all of us want to actually see a little bit more information. So we know that the EPA has had a program where you can apply and to receive an additional designation. And this is called List N designation that says, okay, your germicide has been evaluated by the EPA, and it actually has some demonstrated effectiveness on emerging pathogens. So this really started and came into the forefront of our consideration when we were doing a lot of the Ebola training, and people wanted to know, is this germicide going to be effective against Ebola? So that that designation as a germicide that addresses emerging viral pathogens came into being. So you will see some of the products that will promote their germicide as being on this list. So you can easily go to the EPA.gov website and you can find that list just to be sure. But keep in mind that this virus is enveloped, so it's going to be killed quite easily by the germicide. Our challenge is to make sure that the germicide actually comes in contact with the virus wherever it is so it can actually do its thing. Keep in mind also that germicides are pesticides, so there's no such thing as a green germicide. A pesticide is a chemical. So as we have discussions, and I'm reading this more and more, I ran across something that was published just as I perused the internet, but it was a Bloomberg article. And the question was, are we inundating the environment with pesticides in response to COVID-19? And I think certainly we have to be considering that. But that means that anytime we use a germicide, we also have to have some type of a plan about whether it's appropriate use or conservation or whatever. But that means making sure that we're using it correctly, we're mixing it correctly. I go back to that Goldilocks and the Three Bears. We don't want too much, we don't want too little, we want it to be just right. And making sure that our personnel that have anything to do with germicides know that a more concentrated solution, that means a less diluted solution, is not necessarily a better solution. So following those manufacturer recommendations very specifically. Our focus also for germicides are on those surfaces that are non-porous. So I mean, like not material, the types of things that we see on chairs or carpet. That we're looking at the surfaces that are likely to be contacted during routine patient interactions. All right, so let's move on forward. OSHA, we have to remember that, you know, OSHA is here to protect the worker. Remember, OSHA is not here to protect the patient. There is no consideration about the patient from OSHA perspective. It doesn't mean they don't care about him. It's just that is not the focus. The focus is on any type of worker that is coming in contact with any hazard in the workplace. We need to be thinking about hazard. This is relevant to us right now because as you read a lot of information about types of personal protective equipment that should be used, we're reading that, you know, a number of documents are out that to me say, you know, the world should live in a respirator. Well, I don't know that we have data to support that. If a respirator, if you were going to come in contact with aerosolized particles, then respirator, yes, that is the current CDC guideline. But we need to think about our environmental services personnel and to consider where are they going to come in contact with an aerosolized virus. Then at that point, you wear a respirator. Otherwise, that you use then whatever is relevant to the particular type of germicide you are using. So having clarity in policies and procedure is really important because I go back again, wearing a respirator is tough. I'm sure most of us have worn a respirator at least for 15 or 20 minutes. And you know, after 15 or 20 minutes, it's hot and you have a perception that it's difficult to breathe. Your hands automatically will begin to go to your face more often. If we have environmental services personnel that are actually doing physical removal of microorganisms on a surface, we do not want their hand going back and forth to their face. So making sure they have opportunity to be in that risk-benefit realm where the risk is truly assessed so that we can make sure our personnel are wearing the correct items. This is one of our challenges with OSHA. Fortunately, I think our CDC guidelines align very well, at least at the present time. All right, I want to jump right into what we need for environmental services workers. So I want to look at what the CDC guidance says at this time. Now, if you go to the CDC website, cdc.gov, and you put COVID-19 in the search engine, you will get more documents than you will be able to read probably in a month if you just sit there and try to read through them. And keep in mind that the idea of maintaining them on a website means that you can keep the documents fluid so that they're addressing what we are currently seeing. We know that we have only been involved with this outbreak for not even 6 months yet. So we are still learning. So every day our documents change. So you may have noticed that on some of the guidelines, it used to say that we needed to keep rooms empty for 24 hours. We would keep people out of an environment where we had a patient or an individual with COVID-19. And if you're going to enter an environment within 24 hours, wear a respirator. Well, as we gather more information, those recommendations are adjusted to be in line with the data. Remember, that's CDC's responsibility to gather data and make sure guidelines are evidence-based. So by having them on a website, you will see current updates and changes. Documents that are in hard print are not, that's going to reflect whatever was relevant or in action on that particular day. So I will always go back and look at what does the CDC say, what are the links, and then looking at the documents that those links will take you to make sure, and always be looking at the dates so you can make sure that the information is the most current. All right, as of today, EVS workers who are cleaning an unoccupied room, so EVS workers who are cleaning and disinfecting areas potentially contaminated with the virus need to be trained on what to do in that environment. And that means not only what they need to do, but the type of PPE that they should be using. So things to remember is that when we have a patient that has been diagnosed or even clinically suspected with COVID-19, because we know our test is not perfect. So if clinically this patient looks like they had COVID-19, we were treating them as if they had COVID-19, once they are discharged, you want to shut the room door because the environments in the healthcare facility will have air exchanges. They will be required to have specific numbers of air exchanges, and that will vary according to the environment. So rooms that are the traditional airborne isolation rooms may have a higher air exchange because of the ventilation system than do rooms that are our traditional med-surg areas. So there should be some leadership from infection control that should say, okay, based upon the air handling in my particular facility, it takes 13 air exchanges to get us to a 99.9% exchange of all air, and then a reduction then of the microorganisms in that room. And that takes, based upon the calculations of how many times it takes air to exchange and how many air exchanges it takes to achieve that level. There is a specific table, and I'll show you an example of that table in a minute, but it'll tell you how long it takes. So the patient room door should be closed for a specified amount of time. Most of the time, it's like 20 or 30 minutes. So EVS should not go into the room for that period of time. And then when they go in and the room is unoccupied, they should be able to wear a gown, gloves, and a regular face mask. An N95 is not required. Now, remember, you can always be more prescriptive in your facility. You can say that just to make sure that everything is standard and that everybody knows to do the same thing, we will have everyone wearing a respirator. You can certainly do that. Just make sure there's some consideration about how well you would be able to wear a respirator. If you are in a room and you are doing the mechanical cleaning, that's a lot of energy, a lot of heat, and a lot of discomfort and a lot of sweating that's going to occur. That person then is going to be touching their face to move that mask because they're going to be hot. So understand, again, risk benefit. If you can't wait for physician or for sufficient air exchanges, then you clean and use PPE as if the patient were still in the room. So at that point, then you would go back to N95 or respirator. I mentioned this table. This is a table that's in the TB standard that we have always referred to that let us know if we have a patient with Mycobacterium tuberculosis in an isolation room, we look at the air exchanges that are present in the environment. So let's look at 12 is very common. If you have 12 air exchanges per hour, that means it takes 23 minutes for the room to be exchanged completely, so that mathematically you remove 99% of the microorganisms that were in that room and in the circulating air. If you want 99.9, then the room needs to be, it takes 35 minutes for that to happen. That means door closed and that amount of time. So you make those calculations based upon an understanding of the ventilation system in your facility. So people that are in infection control, that's why I say that I never knew when I entered infection control that I would need to be an engineer also, because I didn't understand this. So I've had to learn about, how does airflow work, and I've had to learn to read blueprints, which, I'll be the first to admit, I have no spatial awareness. I can't, when I get out of an elevator, I always turn left. That's just my automatic. That may not be the way that I want to go, but that's just what I'm conditioned to do. And so I can't find my way, home without GPS. I can't. So I have to develop an awareness for that, and I'm still not very good at it. So I've got to find other people that are really good that can help guide me. So in infection control, it's important that we understand these considerations about, and we need to know our environment, know our facility. And if we can't understand, we find somebody else that helps us. So, getting to know your engineer, whoever is your plant operations person, is really critical. Okay, so we talked about an unoccupied room. What about an occupied room? Well, EVS, whoever's cleaning and disinfecting that area, needs to be trained to do that, and they need to be trained on the appropriate PPE. If we are wearing respirators, then we have that requirement from OSHA that a worker should be fit tested. We know that we have the temporary statement from OSHA that says they realize that this is problematic, that everybody can't be fit tested, because the idea of fit testing is I'm fit tested for a single type of respirator. If I have 3 or 4 different types, then following OSHA, the OSHA regulation, I would have to be fit tested for each one of those respirators, which makes absolutely no sense. For somebody, for me, I went back, and because, you know, everybody knows I don't know how to actually do anything else other than infection control. So, you know, I don't have a hobby. I don't know how to paint, or, you know, I don't know how to do that. So just for fun, I went back and read the minutes from the meetings where they talked about, there were OSHA discussions and NIOSH discussions about respirators. And I was trying to understand, where did the whole idea of fit testing actually happen, and where's the data behind it? Well, I came to find out that there really wasn't any data. It was just kind of put in that because we do fit testing in, you know, in industries where noxious fumes and lethal gases occur, that should be translated to a paper respirator, which makes no sense to me, but the law is the law. So my question has always been, how does this make sense? Because, you know, we have to figure out how to be reasonable to make things work in healthcare. So we know that fit testing already is a little bit of a problem, but again, that is the law. But if I'm going to fit test somebody, I have to fit test them for every mask, every respirator, I mean, that I'm going to be using. And many times that respirator couldn't be used again. Either it would be torn if I'm doing the particulate type of measurement. So OSHA said, wait, this makes no sense on a variety of levels, so we no longer have to do that. But the most important thing is, if your personnel are wearing a respirator, they should fit check it every time. That means when you put it on, you need to make sure that that moment for use, it actually is providing you with some type of seal. So we teach people to do that quick inhale, exhale. That respirator should move, and that's showing they're pulling in the air through the filter. So make sure our EVS personnel are aware of that fit testing process. Management of laundry and food utensils and all of that, we're not doing anything differently for COVID-19. And we need to watch each other and help each other. So that means consistently evaluating the performance. So none of us are perfect. That all of us need to have somebody helping to make sure that we identify areas where we don't use we don't use our technique as well, so that we're wedded to good practice. All right. So then we have our first case study. Then.
So before we go to that, excuse me, I think you meant to say make sure your environmental service workers are aware of the fit check instead of the fit test.
The fit check.
Yes.
Thank you.
Okay, so Joan is an environmental service worker. She has been assigned to the COVID-19 unit in her facility. She has received training specific to the use of the personal protective equipment and the germicide that's been approved in her facility. A question has come up regarding whether or not too many chemicals are being used and whether or not this impacts her safety.
Yeah, I felt like this is a very interesting case, and it really is timely because you probably have had either patients or family members or maybe even students to say, I smell that chemical, is it hurting me? Or everybody is so worried about chemicals, can't we do something green? Or can't we, do we need to use all these chemicals in the environment? We're now having some patients that are requesting a chemical-free environment, that when they come to the facility, they're saying, I can't deal with this, and I need to have something that is without the use of chemicals, just due to real or perceived sensitivities. And again, if the patient perceives it, it is real to them. And so, what do we do in that area? So this is where I think we have to be very good about discussion with our workers on how we mix chemicals. So many of us now are using, and we're finding a lot of interruptions in our germicide supplies. It's really hard to get some of the PopUp Wipes now. Many are on back order. We're just getting a portion of what we ordered. And there is the inclination for people to say, this is a problem organism, therefore I've got to make sure my germicide is strong enough. So we're seeing alterations in some of the fill stations so that people are kind of doubling up, or I'm gonna, normally I add a half a cup. I'm gonna go ahead and add a little more to my bucket just to make sure. this is a problem, that it can result in issues, in inhalation issues, or it can result in skin irritation. So making sure that we're doing just the right thing with our germicides, and then to remember that the products we use are important in addition to the germicide that we use. And so we can maximize our ability to be effective with environmental disinfection if we look at all of the products instead of just the germicide. And I think I'm going to talk a little bit. Let's move on. So, Debbie, are there any questions or comments, or have you had interactions with patients that are asking about too many chemicals? Perfect. Well, maybe it's only in downtown Louisville. So this is, I'm assuming it must be at, maybe it's downtown.
We're too bougie.
So,
we're too bougie.
Yeah. So I don't know what it is, but making sure people understand product safety. And so we all have to get to know these general harmony types of symbols, so that, these are universal types of symbols. Make sure that everybody is aware. We've seen a lot of these issues in our environmental services personnel that may be individuals who speak English as a second language. So if we have then groups of internationals that may be part of our environmental services department, make sure that they're aware of what these symbols mean so that they can understand the chemicals that they are using. Also, make sure that there is recognition of chemicals that you cannot mix. So, like, don't mix ammonia and chlorine. You'll kill yourself with the gas that is produced. And we've had situations where we did a lot of work with some of our incoming refugees and I thought this was a really interesting thing that never dawned on me. But we had some refugees from Ethiopia, I believe, who love lemons, and everything lemon is a good thing. But there was a problem because many of our germicides have a lemon scent, or would even have a picture of a lemon on the outside label. There was the thought that this is something that you can eat. So make sure that if we are providing chemicals to our workers, make sure that they are aware of the safety components that may just be second nature, or just maybe common sense to you or to me or to others, but may not be common sense for the workers that we have. So keep it in mind. I had a discussion with a group of refugees, and I think we even had a mom that wanted to give her children, increase the fruits that her children ate. And so she was giving them hand soap that smelled like berries and had berries on the label. And so the kids were being given a spoonful of that, thinking that this was helping them. And it wasn't until the children, began to have problems with vomiting. She took the child to an urgent care that they discovered what the issue was. So one of
that's a great challenge. And everything you're saying, because we do have a lot of people in our facilities who do not speak English as their first language. We had another refugee who put their important papers in the drawer under their oven and caught the house on fire. So there's we can't assume that they know what they're doing and doing it safely.
And there's a lot of information out there now about poison control calls during COVID-19 because people are assuming more is better and harming themselves. So
it's a natural instinct, right? We want to kill the bug.
So keep that in mind with your patients. You just don't want to make assumptions.
Yeah. So training is important. All right, I want to get in a little bit next and talk about some of the supplies that I mentioned. The next slide is, and I just took this graphic. I don't know who Mr. Siga is or if this is his personal brand. It was just a nice colorful picture of microfiber cloths. Microfiber is one of the best things, in my opinion, that has happened to environmental infection control in a long time. It's interesting, but this cloth is technology. That the cloths are made of types of fibers that are really plastic. And if you look at them under the microscope, they're split. And so you've got one fiber that, is all apart, and it's very good at actually grabbing the microorganisms. And some studies in Australia actually said that they were looking back at the use of microfiber and using water as and not a germicide, and that they were having tremendous reductions in the microorganisms that are on the surfaces, that these cloths are fabulous. Now, I'm not proposing that we not use germicides, not at all, but I'm just saying microfiber cloths are amazing, and that we're seeing them then brought into facilities, and they're using multiple colors to actually help environmental services do things like remembering to use a different microfiber cloth when you go in and you're cleaning the bathroom. So like the bathroom might be red, and what you use in the room is yellow, and what you use on the patient's bed is blue. So it's helping them realize that you change those cloths periodically, and that as you move from the cleaner area in the room, remember when we're cleaning a room, we move clean to dirty. Typically, we think of that may be the opposite of what we think about in some patient care scenarios. But in cleaning a room, we do not go to the bathroom first, because then we pull in potentially whatever microorganisms are in the bathroom, and then we'll contaminate the rest of the patient environment. So microfiber is great. There are a couple things to know though about microfiber. So many of you probably have them in your house. I mean, Dawn and I were talking, there is nothing better to clean a window than a microfiber cloth, because
what's even better is give someone else your microfiber cloth.
When somebody else cleans the window.
Yeah.
Good, that's even better. Yeah, so yeah, my cleaning is probably not great.
But they're great.
But they are great. And so if you look at, I think Rubbermaid has some really good products. So if you look at the environmental services, their cart, that now they kind of look like I call them the rolling barbecue. It looks like a barbecue grill. It's got a big rounded top, so they're rolling the gas grill around. But in that, there are places for them to put containers for microfiber cloth, and the container will actually show them, now stack the microfiber cloths to this level, and then pour in this amount of germicide. Because microfiber cloths do not work well when they're saturated. They need to be just damp. So there is a specific recipe, almost like baking a cake. I use this amount of fluid to wet this amount of microfiber. So you've got the germicide in the cloth, but it's not clogging those fibers. Otherwise, it doesn't pick up the microorganisms. So you need to know how to use these cloths. Also, if you launder them with cotton, the cotton fibers come off of that other rag, and it blocks and locks those fibers, so you lose the effectiveness. So not only do you need to know the recipe for wetness for these cloths, but you also have to make sure that they're laundered correctly. So if you have microfiber at home and you throw everything in the laundry, your microfiber will not be effective beyond that first washing event, because those fibers will be completely clogged. They are so small and designed to be movable, and without that protection, they'll be clogged. Also, if you put them in a hot dryer, remember plastic melts, so those fibers will actually melt, and you'll be able to feel how stiff they are, and it'll feel like plastic melted. So this is a problem. I saw a note from Delner. I had one of my colleagues, Hudson Garrett, that was going to join us today, but Hudson got pulled away, unfortunately, as part of his COVID-19 work responsibilities, and was unable to be with us. So I'm going to try my best to fill in for him, and I'm sure he'll let me know if I fail to mention anything when he goes back and does this review. All right. I want to check with you guys. How many of you all are currently using microfiber in your facility, or how many don't know? Are you using this?
So the poll is launched, and I've added, based on your feedback, not applicable, so you all can answer it no matter what environment you're working in. And so we're getting a good response.
If you're in an academic setting, you know, that if you're like at U of L, I'm not sure how often we get clean, but it's probably not measured in days. It's probably measured in years.
In this building, at least.
Yeah, so we may get, you know, we may actually get clean, you know, once a year. So if we do, then making sure that somehow microfiber cloth is involved is really good. And we're making it available. Like we use it in our clinics to use with our disinfectants, just because it's really good.
So we've got about 59%, so a little over half responding. So we've got 32% that had said yes, they're using them, 18% said no, 18% they weren't sure, and then we've got about 30% that it wasn't applicable.
So if you're in a healthcare setting, this would be something good to find out, are using microfiber, because environmental services personnel have a specialty organization, an association that is really quite excellent. It's part of the American Hospital Association. It's under the American Hospital Association umbrella, but it's the Association for the Healthcare Environment, or AHE. So if you're in a healthcare facility, it would be really good to talk with whoever is in the environmental services department, because they may not be aware that there is this excellent resource. They have so many, they have webinars available, they have an excellent annual conference. The personnel there are so good to work with, and they are so focused on education. I think have done a number of really good outreach activities. So, and I think they just published a new document that in the past it was called Practice Guidance. I can't remember if they kept that name for the new one or not, but in that they have policies and procedure examples, and it's a really good handbook. It's almost like a policy manual or a how-to, evidence-based how-to book for environmental services. So I really recommend you get to know them and reach out. All right. Another thing that we're hearing a lot about, and you may have heard this term, MYOW. So it's not, you know, BYOB, no, it's MYOW, and it's make your own wipe. And this is really in direct response to the problems, the supply problems that we're seeing now, it's hard to find our can of PopUp Wipes that we've always been able to get. If you are getting some, most likely your supply has been greatly reduced. Even some of the largest purchasers across the United States are not able to get everything. And we know that, you know, the biggest purchasers that are the biggest dollars oftentimes get to kind of, you know, muscle their way to the front of the line. They're not even able to get what they want. So this whole idea of making your own wipes has emerged. Now, in the past, you know, the pushback was always, well, no, we don't want you to do that, because, you know, these are paired items, the germicide and the roll of towels, that the effectiveness that the EPA measures is how well you are able to reduce the microorganisms when you use that system together. So you can have a really good germicidal wipe, but once you pour it over some unknown type of paper towel, then that all the EPA data are no longer relevant, because you don't know, are there any chemicals? You know, most of the time there's formaldehyde in paper. If you're adding formaldehyde to the wipe, is that, you know, changing the effectiveness? So in the past, there was always then the pushback from EPA saying, please don't do that, because we don't know what the final product is going to look like. Now, however, more and more disinfectant companies are saying, you know, we're checking the reality of this, and we're not finding that there are issues with these combinations. So if you need to make your own wipe, then make your own wipe. So a number of companies like Kim Wipes or Kimway makes available these rolls of, it's not like a roll of paper towels, but sort of, where you can, you know, pull it out from the middle, and we'll provide them dry wipes in the actual canister, so you just pour the germicide on top. So if you find that you are unable to get the traditional or the standard environmental wipes, these make your own wipe systems are becoming much more popular, and I think something that we'll have to use. Because again, we're seeing shortages now when we're at a relatively low level of COVID disease. We are learning that the White House was making the statements that there may be seasonality associated with this virus, and and people were saying no way. Well, now we're seeing there is seasonality associated with this virus. That with a warmer climate, as the relative humidity goes up, that seems to be unfavorable for the virus. So we have seen then rates of viral illness even in some of our high congregate setting events. So there is some reason for us to think there is some seasonality. That's the good news. The bad news is there's some seasonality. That means when it gets to be fall and we're losing the heat and that higher relative humidity, the environments that typically are those that viruses seem to love and thrive in, that is why we may expect that resurgence in the fall. So this is a time just to do that plug to say we're going to have to make sure that we're focusing on influenza immunization for our entire population as we get to fall, and also keeping a close watch on the comments we're hearing from our patients and communities that may give us an indication on any challenges we may have to deal with when we have a COVID-19 vaccine, or if it's like the Kentucky Derby and we see 10 different types of vaccines that are all coming to market at the same time. We're going to have to figure out what that means to get it out into the public. So, all right, let's move on forward. I'd love to know just from you guys, what types of what's your kind of pop-up wipe experience? Are you currently using those pop-up wipes, or have you been involved in any of these initiatives to make your own? And if you have any comments or experiences, because we spend so much time trying to say everybody's involved in environmental disinfection. So if there's a box of pop-up wipes, everybody use them, wiping off things of telephones and things that we use a lot. And now we're having trouble getting those supplies. Do you have any insight into what these responses have been?
We're getting about 41% responding. We'll give it another minute or two. And Ruth, like you said, the make your own wipes has become like a movement almost, especially in the public too, where you couldn't get wipes just for your generalized cleaning. So you saw everything from YouTube videos to written descriptions on the right balance of the chemicals and the levels and everything. So that started almost like a grassroots movement.
Yes, truly.
So we've got a couple more responses coming in. So we're about 54%. So we have about 62% of our respondents saying they do use the pop-up wipes in their facilities. We've got 67% saying they are not using make your own wipes in their facility, and only 3 respondents had said had said that they are using the make your own wipes in the facility. And I'd love to ask those 4 people that responded, maybe if you want to comment on the make your own wipes and what you're doing and what kind of pushed you all to do that, whether in chat or you can feel free to unmute yourselves.
I've had a big concern with our long-term care facilities, because my sense is that, if there has been any challenge in obtaining germicides, if you only use a certain level, getting more in response to COVID-19, it may have been a challenge if there is, a lack of big group purchasing muscle, or if that's been a problem. And so making sure people know it is okay to make your own. Just have a methodology for doing that. But I'd be interested if we have anybody from long-term care that has a comment about this.
Oh, Nina said, I do home-based care, and our company has had trouble getting enough supplies. So we have gotten instructions on alternatives and how to make them ourselves. Nurses are resourceful. I know that for a fact, seeing that come out so much in COVID-19 as well.
All right, good. All right, so I want to bring in just some reminders about reusable medical equipment. Please make sure that we're paying attention to items that we share among patients, and that there should be policy on the part of the facility, whether this is a healthcare facility, but also we're even looking at, we teach CPR to our group. We've got to make sure that, the face of the CPR head is disinfected, and that even means its mouth. And, we continue and of course always provide the face barrier so that somebody can use that. But, we're looking at all equipment to make sure in the academic setting, simulation settings, as well as healthcare. Right. I see Kristen made a comment. We have long-term care. We've used wipes for things we have to use them on, and sprays for things we can't. We have to make the decision on what cleaning and how your supplies are allocated, and then remembering about resident safety. I think that, that is huge. Spray, we know that sprays can be problematic because remember, when you are spraying into an environment, you're enabling the user to inhale that. So I think I'm going to mention a little bit about electrostatic spraying. That's become a huge issue in healthcare. We're seeing more and more about, the distribution of the germicide with a spraying device. Those can be very effective and use fewer amounts of chemicals. You use less, actually, the data are showing us, than you will use through a traditional disinfection, but you have to clean before you disinfect. So it may increase your labor a bit, but if we're worried about the amount of germicide, the electrostatic sprayers may be something that we can look at. See somebody else in long-term care had difficulty obtaining them, but you've gotten a good response. Oh, good. Mm-hmm. People have donated and made not only germicide but PPE. Fabulous.
It's amazing. And if you all are running out of supplies, I would encourage you to make that ask to your community. And we've seen the community has come out to support healthcare workers and especially nurses.
So some of the enhanced environmental cleaning, and I put a couple of items on here. The top picture shows the process that's been used to disinfect respirators. The device that you can see on right behind the person in the white gown is the hydrogen peroxide sprayer. It actually fogs or fills the room with hydrogen peroxide vapor and exposes in the respirators. We talked last week about some of the problems that is causing. It's a good thing. Also, we know that it does have an impact on the material of the respirator and may not be able to, and certainly we can't decontaminate respirators more than just a couple of times without identifying problems with that. But the distribution of the germicide into the air is one approach. And I mentioned the electrostatic sprayer, and it almost looks like, if you use the weed blower in your yard and you put it on your back, if you see the lawn companies walk around with that, that's almost what the electrostatic sprayer looks like. Only you're spraying then a mist, and it's electrostatically charged, so it binds with the particle. And actually, so we've got the viral particle, the mister then attaches just through that positive and negative attachment, and then will disinfect or will kill that virus, but it has to get to it. So that's why we talk about the removal of the soil. So removal of the bioburden before you do electrostatic spraying. So you've got to clean and disinfect in two separate steps, which may be a little bit different than our approaches in some facilities that are using a combination germicide and detergent that enables you to do both of those things at the same time. So looking at available equipment and how to use it is something that we need to give some thought to. The bottom picture shows one of the freestanding UV lights that systems that are available. So we'll talk a little bit about why you use UV and why that's an enhanced technology and what its role might be in the setting. All right,
I will begin disinfecting your room in 15 seconds. Please leave the room.
So the 4 bad pathogens that we included in our study were MRSA, vancomycin-resistant Enterococcus, Clostridium difficile, and multi-drug-resistant Acinetobacter. And these are the kind of the top 4 of bad bugs that we'll see in hospitals. When patients get infections from these organisms, they have prolonged hospital stays, often require intensive care, and have basically, a major interruption in their life because of the ill effects of these types of infections. There are several different interventions we use in the hospital to try and decrease the transmission from these pathogens. Hand hygiene is a big focus. We also use what we call contact precautions, where for patients that we know have these pathogens, we'll wear gowns and gloves and then discard those gowns and gloves when we're done caring for that patient, so we don't then carry that organism to the next patient. And more recently have really been focusing on the environment as a way to decrease the transmission. So in our study, we trialed 3 different enhanced strategies for cleaning rooms in the hospital. And what we found is that if we added a UVC emitting robot to our standard cleaning, then we could actually reduce the transmission and infection from these 4 bad pathogens by 30%, which was a significant finding from our study. So we are now in our hospital using standard chemicals for cleaning, but then once we're finished with our routine chemical clean, we'll roll in a UVC emitting robot, turn it on for approximately 30 minutes, and add some enhanced disinfection to the room before that next patient then comes into that room. We had 2 tertiary care centers, Duke and UNC, a VA, and 6 different community hospitals. So there was good representation of all of the different areas that care is provided. And we found that in general it was effective in all of those settings. And so I think it's important that we have pretty good generalizability from our study, and that we think that it's an effective strategy not only in the big hospitals like Duke, but in small community hospitals as well.
So that was a bit of information just kind of
I will
showing
begin
one of the UV lights. As you can see that the lights are freestanding and there's no patient in that bed, even though that little lumpy thing at the bottom is not their feet. There is nobody in the room when these lights are used, and that is purposeful because you do not want people staring at the UV, staring at the light. Exposure to UV radiation does have some potential negative impacts. And so we have to really be looking at the worker safety and having a thoughtful approach. Now, it doesn't mean those UV lights are dangerous. I'm saying that we just have to use them with a thoughtful approach. These are a couple of examples. They're primarily 2 different types of UV devices. One is the stand-up, kind of the mercury-based lights, as we're in the example that Duke showed us. The other is a pulse xenon, that kind of a flashing light. 2 different manufacturers, 2 different types, but both of them use UV radiation. And they really are embracing the whole notion of robotics. Some of them now you can use an iPad and kind of dial in a pathway so that the light can move through the room. Because one of the issues with UV, it's sort of like sunlight. And so when we're out in the sun, if we want to get out of the light, we go to the shade, and then we're not as susceptible to the radiation. The same thing in a room. If you have microorganisms that are in an area of that room that is shaded or shielded from the UV light exposure, then there's no germicidal impact. So you have to make sure that the light actually shines everywhere in the room and on all surfaces for it to be used appropriately. So that really brings in our notion of robotics, and how do we bring in then the engineering side of moving these devices around so you don't have to have a person that goes in and adjusts then where those lights are standing. that the automation can help you.
They'll 3D map the room. Some of them will actually 3D map the room, so there is no human involvement. It'll do it itself. It's really kind of neat.
And
Yeah.
I think it's interesting too how it disinfects. It's actually degrading the DNA or the RNA of the virus. So I guess, Ruth, there's still, after the process, you could probably still find little fragments, but it would not be viable.
You are entirely correct. And that's why this is part of like a program, an enhanced program. So when we look at this slide, this shows the spectrum of UV light. So ultraviolet A and B, kind of the germicidal scope is usually between 100 to 300 in nanometers. So we look at the type of radiation and the length of the wavelength. So UVA and UVB are those types of ultraviolet that cause us to get sunburn. So UVA tans us, so the tanning bed lights are UVA. UVB is the more like sunlight exposure and will cause us to have sunburns not only on our skin but also corneal issues. But the radiation themselves will actually affect the cell's ability to reproduce. So it destroys and affects the DNA and RNA. Therefore, UVC in that range of really about 200 to 300 is considered to be germicidal. We're finding that there's a new category of UV that we're calling far UV that we're seeing more and more used in overhead lighting. Mm-hmm. That also has the wavelength that is acceptable for a germicidal approach. And we're seeing even fewer eye issues with far UV than we're seeing with UVC. But right now there's still a lot of research that's going on. And I think Ann said, yep, they damage the mannequin skin in your simulation.
Yes.
That's entirely, and that's one of the drawbacks to the use of UV in the patient environment. We're seeing a lot of absorption of that radiation by plastics, especially in these rooms. So you're seeing like baseboards cracking and other items on the beds that may not be able to tolerate that, because UV light is really radiation. It's UV radiation, but UV light sounds better. And people, I think, are less afraid of UV light in their environment, but it's important to remember it's still radiation.
Speaking of that, they've shown studies now with the masks that the UV light degrades the straps first.
Yeah, absolutely, absolutely. So these are just some things to remember. The shorter the wavelength, the more lethal it is, and that's why we're looking at that part of the spectrum in determining the impact. A and B are not considered to be germicidal, it's UVC. That if the organism is somehow shielded from exposure, then we lose the germicidal effect. So we have to think about how we're going to use UV in the environment. And this also is a reason why you'll see, at least in a lot of the catalogs I'll get, there's like UV wands. So I've got a little, UV wand, and the thought is I just kind of run it over. Well, no, because in order for UV to work, the wavelength has to be appropriate to the type of radiation and the exposure or the dose. It's kind of like with a germicide, we have to have that contact time. In antibiotic, we have to have the dose that's administered. The same thing with UV light. The dose, the actual time of exposure has to be long enough so that the microorganisms will be killed. So a wand, wouldn't work like that. If you have a wand and you're going to hold it over an item for several minutes, then probably that would be effective, but that's not the way that we use wands.
Correct.
So it sounds like a good idea, but has very limited work and use in the workplace. So here are a couple of pictures of these different types of mobile devices. We think of them now as no-touch devices because they are increasingly being combined with robotics so that they can move around. The two types that we have are either the mercury lamps that I mentioned, the low pressure mercury lamps, and then pulse xenon. The pulse xenon, have less of a am less inclined simply because of that pulsing, that I want that, the data that will show me the effectiveness of that reflective light. So looking at the information and brushing up on what you need to know about UV and how it works can help you a lot in making decisions about the types of products to purchase. The next, I think, area goes back to, Dawn, what you mentioned about, well, what happens then and how do we determine how effectively we have cleaned or disinfected? And we have really just, you know, a couple of ways that we can do this, and they're really related to some of the UV limitations, that although UV will kill the organism, its body parts are still there, its remnants are still there, okay? That it does have some other drawbacks, just the impact, the cost, the workflow interruption, potentially if you're having to stop and move the device, and remembering that it does not replace physical disinfection, that we still need to, or that physical cleaning process. We need to reduce then the soil that could act as a shield to the UV radiation. So we still have to have that kind of two-step approach to make sure that it works correctly. All right, our discussion now, I want to focus and just ask you back one of our case studies.
My facility is considering UV as an addition to our environmental infection control program. What experiences have others had with this technology? Have you had any problems? And how well has it been accepted by your department, and especially by nursing?
So I'm interested in hearing, because we're seeing, you know, greater pushes for UV in the workplace. What are your experiences? And you can hold your space bar down if you want to talk, or
*6 if you're calling in on the phone, or you can click the little button on the side of your screen that looks like a microphone and unmute yourself, or you can again place it in chat. We love hearing from you all. It can be a question, a comment, an observation even. You can even vent if you hate UV. There we go. Kristen, you are my rock star. We are only using it for decontamination for N95 masks, but we've had a very positive response. Just be careful of those straps. There was a study that just came out of the Mayo Clinic that it starts to degrade the straps a little bit after 2 disinfections. Only because we don't have the option for the office, yes. So good job. There's a lot of really amazing articles right now about UV light and PPE.
There's a lot of work that's going on in this technology also, both with using UV for lights, also adding UV into HVAC systems. So looking at recirculated air, adding ultraviolet lights then to have any type of particle killing as air is circulating through the air handling and ventilation systems. So I'm sure that, you know, if you have these discussions with physical plant or the engineering department, as people are beginning to upgrade their ventilation systems simply because of cost of, you know, some of the blower devices and some of the filtration devices, that the option to pull in UV is now increasingly considered. But again, if you have airflow that flows around a duct and tends to get caught in a corner, that is a shielded spot. So you still won't be able to have then that broad effect. So when I mentioned getting in touch with your engineer side and learning, you know, about what do we need to know for ventilation is important.
They're also using it in water. We know that for a fact.
Yep. Probably used, I think water actually was the first use of UV back in the late 1800s. They found that water that exposed to sunlight had fewer microorganisms. So then that prompted the entire discussion. So, UV as a germicide has been studied for, more than 150 years, and we're still trying to get it right. We're still trying to get to the point where it's safe and can be consistently used in the healthcare setting. So just the right technology and just the right amount.
I want to let you all know, just in case you want to ask a question, but you want to be anonymous, you can, in the chat, you can choose to privately message us. And then that way we will not say who it is. Just let us know you want it to be anonymous.
Okay. You can, that means you can tattle on anybody.
Absolutely. We don't want you to feel like if you're worried about saying something negative about your facility, we can protect that. And you could just let us know that you want it to be anonymous. And if you privately chat us, nobody else can see that.
All right, so this slide goes right into the heart of some of the things that Dawn had mentioned, and that is, how do we know that things work? There's a big focus on evidence-based testing. And for a long time, we've always employed the whole idea of visual monitoring. That is, I look to see how well something has been cleaned or disinfected, and I judge it just by observation. So, when I first started nursing school way back in the last century, everything, a hospital or a healthcare facility's cleanliness was judged by how shiny were the floors. That was our measurement. That was based upon our visual monitoring. And we assumed if you had shiny floors, you were a clean facility. Well, now we know that it's a whole lot more complicated than that. And so the whole idea of visual monitoring is increasing. And we're looking to develop then biologic markers. So many of you may be using ATP, or the swabs that will say, all right, once we've cleaned or disinfected, or even if we have used UV, what's left on the surface? So some examples and demonstrations. There is a company that I had heard about when I attended the infection control conference in Canada a few years ago, and they had a product there, and I think it was actually developed by an infection preventionist. And the idea was, wait a minute, if I can put this fluorescent marking on surfaces, is there something else that might be on a surface that I could see another way? Because we know if we use like fluorescent powder or whatever, if I mix that fluorescent powder with a little alcohol and I put a dot on surfaces and then go back to see if it was cleaned, you can see that dot. Mm-hmm. So, people can begin to look for the dot and then make sure it's cleaning if that's how we're judging. So this infection preventionist said, isn't there a different way to mark? So in the really creative, just shows again the innovation of nurses, that this person began to look at how might, is there a way to photograph or take a picture, and is there something then that I can see in a photograph if I use different ways of photography? Can I actually see what might be left, maybe like the oil on skin or something that is left on surfaces? So this company is called OptiSolve. So if you ever want to get out and kind of look around the internet, I found it to be very interesting. And so I got together with the people at the company to say, tell me more about this, because I just find it interesting. And it's still an emerging idea, and I think they're close. They're not quite there yet, but they're so close, where you spray an item and that reacts with whatever is on the surface. Then they take photographs and can actually see what's on the surface. So in this picture, the areas that are red are more heavily contaminated than areas that are green, and they are more heavily contaminated than areas that are yellow. So they can make this technology, and they're trying to get faster with it, because I said, the idea is you've got to be able to take a photograph and see it immediately, and not have to, do a lot of like setting up in a photography studio like you're getting your portrait made. But it has to be very fast and with the information immediately available to be able to see this. So it's a really up and coming company, and I think we should really keep an eye on what they're doing and watch and see what develops. Something that is more readily available beyond this type of marking of an environment is ATP, and I think that's the next slide. So, you know, ATP looks for a biologic remnant. So, you know, adenosine triphosphate is in all living organisms, and it's a remnant that is there if it's live or dead. So, as Dawn mentioned earlier, you can radiate an organism, but if you don't remove it, its ATP is still there. So cleaning really is what impacts the removal of ATP. So if you're using a microfiber cloth, you are probably doing an excellent job in removing those microorganisms. That's why so much benefit comes from microfiber. And then the use of a germicide is after that just, you know, kills whatever is remaining. But ATP is used to, you swab a particular area, a surface area. So many of the swabs will say, hey, use this in a 4x4 area. So they give you kind of the idea, and they'll tell you, how do you swab? Like, you don't just go and, you know, none of that concentric circle stuff. You go all in one direction and then you go in another direction. So you completely try to capture what is in that area. And then that swab can be used to show not only the effect of how well somebody was doing their cleaning. So you can use it with your workers to say, okay, let me go behind you and see how well you did on these particular areas. So you can give them direct feedback. You can also, you know, use that to direct feedback from environmental services to say, we want to show you what a good job we're doing. So it can be, you know, kind of a customer facing, like a healthcare worker, or it can be back to the worker facing to let them know how well we're doing. So I think the next swab gives the next slide gives some examples. This is just a device that I think is interesting. You take the swab, you run it over the surface, it goes directly into the device to measure, and then you're able then to, through like Wi-Fi connection, you can deliver that information into a database, so then you can develop a dashboard. So you get very quick results. So I swab, it goes in the machine, it takes, you know, 10 seconds to give me a result, and then I get a qualified result. Instead of giving me a number, the number is already programmed into the machine to tell you whether or not it passes or not, and then it gives you an idea about how well the ATP or those remnants were removed from the environment. Now, the important thing to remember is that if I disinfect or I clean and disinfect an environment, and then I decide to come back an hour later and do a swab, well, how many people have touched, and, you know, how much recontamination has occurred? So if you're using it to determine the effectiveness of your cleaning and disinfection methods, you need to swab very quickly after that attention was provided to the surface. So again, it doesn't tell you what organisms are present. All it tells you is, are there any biologic remnants, live or dead, on that surface? So it is very limited in the information it can give you, but if you use that information correctly, it could be beneficial in your overall environmental infection control.
As I look at this, though, I question the well itself where they're putting the swab. I wonder how they keep that, and you don't have to answer this, but keep it from becoming contaminated so that when I put the next swab in, you know, almost like a spillover in the, I don't know, I just find it interesting how the technology behind it.
Yeah, I think so. It'll be when the swab is taken, there is a buffering solution that you put the swab down, you have to kind of crack the end. And I just know how this, just because I have more familiarity with this type of swab, but it's that solution that actually will prevent that very thing that you're talking from contaminating on the inside. But your observation is great, and I hadn't thought about, oh my God, well, is this something that you need to compare device to device? So it's a great observation on what to ask then as you're looking at some of these devices.
That's what COVID-19's done.
It's made you ask questions, that we didn't think about before.
Just a quick Google search, you can see these ultrasnap, the swabs themselves and how they work. Lots of videos out there to show you if you are intrigued by that.
I think it's certainly a something to think about. And we also know that, patients are in all kinds of areas and their families and visitors. So, most of our disinfectants are designed for non-porous surfaces. So think about how you are cleaning and disinfecting, things like chairs and carpet. It may not be as easy to do, but make sure that whatever items that you are using are appropriate. And it's another reason why I thought we got rid of all material chairs, because we were all afraid of scabies and lice. So I thought, they left and bed bugs, yeah. So you may not have many of these material items in your facility as you used to, but as you are replacing items, if you can get get chairs and so forth that are not that porous material, that would be quite helpful to your environmental services department, so that they have things that are a little bit easier to clean than the material has been. All right, hand hygiene. We can't ever talk infection control without just the reminder about hand hygiene. And keeping our hands clean is critically important in any environmental infection control approach, because it is our hands that contaminate the environment, and our hands that enable movement of microorganisms from a contaminated environment, either to ourselves or to another patient. So that combination of clean hands and clean environment provide a safety level for workers and patients and everybody else.
You've combined that with UV light, with the powder, and seeing how many times someone has touched themselves, how clean their hands are, and it's a little disturbing in nature sometimes.
It's a reminder. People think that if I take my glove off, I don't need to wash my hands. No, gloves off, hand hygiene. All right, I think we have lots of questions now from people too that are going home, going home with COVID-19, and they're asking about, what do I do at home? This, I think, is a great example from CDC, that their items are great and that you can put your own stamp on it as well. And make it kind of personalize it, but this is something for cleaning and disinfecting your home. A bit about, what do we use for household cleaning? How do we make our own bleach solution? This is a reminder, not all bleach is the same. Discount bleaches have fewer parts per million than do non-discount bleaches. So I tell people, this is one time that when you're going to go to the grocery store and buy bleach, if you're going to make a bleach solution, buy Clorox, because then you'll have that standard. If you make that 10% bleach solution, you'll meet the parts per million recommendation that provides you then with a standard type of disinfecting solution.
I think the thing I learned most importantly is the wait time, and the proper amount of time to wait, depending on the product, both at home and in the office.
Yeah, the contact time.
And I don't think most of the public knows that for these products.
Yeah. So contact time that's the time it takes to dry. So letting it be wet and stay wet and dry on its own. So don't wipe something and then think I need to go right behind it and remove the wetness. You have minimized then the kill effect, or the opportunity, because not all organisms are killed immediately. They have to have time to be killed by that product. So let it stay wet, and a surface that is disinfected should be completely covered with a disinfectant. So spray bottles, if you do like I do, you kind of spray and you make like a big Z on the item that's going to be disinfected. Well, only the Z actually came in contact with that disinfectant. So you have to be very careful if you're using a spray, so that you've got it on the mist instead of that jet little turn that you do, so that it's completely comes in contact with the environment.
And then speaking of a wait time, we had a question about a church using UV wands for cleaning between surfaces, and she said, how much is the most current information available to the public and non-medical facilities or businesses, both on these cleaning products and the cleaning aids like the UV wands?
Yeah, it's hard. Many times it's people that are making the decision or doing the best job that they can to answer questions. But somebody knowledgeable about, look at, all there is to know about UV. that it's hard to make those decisions if you don't have a little bit of background. So, you know, the wands are just not going to be effective. They seem like they would be great. And, you know, to me, anything that looks like a Star Wars movie, I love, but they just don't, they're just not going to give you the desired effect. So if you are going to be using UV, then you really need to have those larger units that are going to provide that radiation. But again, remember, you really need to be within 6 feet of the item to be disinfected. That's why you have to move an item around. So if you have a large church environment where you've got a lot of pews, you know, UV is going to be very difficult. You're going to have a lot of movement, and it's not going to be the type of device that you are probably going to be able to use between church surfaces and get that desired effect. So, you know, getting somebody that knows about UV to help then form a strategy for using that will be the most beneficial.
And now you are the ambassador, knowing a little bit more than you did before about UV. I would potentially suggest that you talk to your church and tell them what you've learned today, and be those ambassadors for environmental cleaning in your social settings.
Yeah, I found it interesting that there are not many really good documents to help the lay, you know, help me. I had to ask a lot of questions of a lot of people that understand this much better than I do before I felt like I really understood what the information was telling me. So those of you that you know, are writers that want to have something to write about, it would be great to have the basic information about UV and environmental disinfection for, I don't know, UV for dummies, I guess. That would be what we could certainly use, because there are very few good documents out there to guide this type of decision making. So
we're looking at schools as well. This might be something, if you all have little ones and you want to participate in your school district, this would be a good way to do it.
Yeah. All right, so I know our time is coming to a close, and I want to focus on kind of the takeaway points that routine cleaning and disinfection is really a procedure, and the procedures need to be developed and followed consistently and correctly, especially for their focusing on patients with fever and respiratory symptoms as COVID-19. We have to have a process to routinely disinfect. Reusable medical devices are those that are disposable. Get rid of them, or if they are being reprocessed, follow reprocessing guidelines very carefully. Those items should be addressed using manufacturer's instructions. What we call the MIFU, or manufacturer instruction for use. Those will outline specifically how to use products and services. And then make sure that if we're doing environmental disinfection, especially in the time of COVID, PPE is important, and how we manage disposal. And what our regulated medical waste regulations are. They differ per state, so make sure that we're aware of what we need to throw away when and in what type of container. So with that, we'll be able to take any additional questions or comments that you may have. Make you want to run out and buy germicide and a UV light.
And get a flu shot.
And get a flu shot, yes, please. Heavy on the flu shot, yes, yes, yes. So interestingly, UV started off in primarily used in food service. So we learned a lot from the food service industry, because, you know, they would swab surfaces that could be flooded with water to just wash away those biologic remnants. And so we began to see, wow, if they can use it in food service. And then we began to use UV and swab endoscopes as a way of determining how well that they were cleaned and disinfected. So it's had quite a journey in healthcare, but it shows the value of learning to get what's a proper and good use.
We saw it in Whole Foods has used UV disinfections for a while. I was trying to share an image and it wasn't working, of UV light, utilizing it in a hotel room on a door handle.
Yeah,
no, it was a little bit. I'm glad it didn't work.
So somebody asked about when flu vaccine will be available this year.
That's a plug for an upcoming session of the combined influenza and COVID-19 twin pandemics, as we love calling them.
So I don't know that we have information. We hope certainly that there won't be any delay. We don't even know, and I think there's still a lot of discussion on what is going to be the general sentiment about flu vaccine. Are people going to want it more? Are people going to want it less? What's going to be our impact? Of course, it's our hope that that we are going to see tremendous impact in people that want influenza vaccination. But I would expect and hope that we begin to see our shipments like we normally do, which is in late July, so that we're able to begin vaccinating in August. That is our hope. Our challenge is going to be where vaccine is going to be available. I went into my Kroger the other day, and there's crime scene tape up around the pharmacy area that nobody can sit in the pharmacy. So if a lot of our patients have traditionally gotten their vaccine from pharmacies, I don't know, maybe the crime scene tape will come down as flu vaccine is made available. But, you know, the thing about nurses, if you're looking for a vaccine, everybody knows you always have an in, you know, an in with nursing, that will always be able to find flu vaccine and can figure out how to make sure it gets into the arms of our healthcare workers. So if anybody ever has any question, you could always give me a call, and I could figure out and find out and share whatever I know and make sure that everybody's got access. I want to also make sure that if we have anybody from our long-term care community that is on this session, we want to make sure that flu vaccine is available to our healthcare workers in all settings. So if you ever find that you have difficulty, please reach out, and we will find a way to make sure that you've got a nice firm pipeline to vaccine, or if you need groups that can vaccinate you. Delaware has already shown that the K&A can help in pulling together groups that can help with immunization efforts. So generally, if you have a problem, let's throw it out to this community of people that work together. Let K&A know about your problems. You can always email us here at the University of Louisville, and if we don't know, we will help figure it out for you.
Especially our friends from outside of the state of Kentucky, we will ensure to connect you to your state. And so the influenza plug, that will be July 1st. Be sure to watch that. We're all been very fascinated looking at everything from the plague all the way on, looking at pandemics. It's been really fascinating, at least if you find that fascinating. As well, next week is a very, very important session. I know Delaware had talked about it before. We're looking at resilience and stress management during the time of COVID-19. We'll have a lot of guests with us that specialize in that, although Dawn is Ruth's counselor,
she's my
confidant, the couch, you know.
My therapist.
But we really wanted to get people plugged in to help you all, especially. And that session will have lots and lots of resources for you in box. We'll try to provide national resources as well for those of you outside of the state of Kentucky. But I would very much love, you'll get an email about the case report. If you all want to put in questions, comments, concerns, observations of colleagues, again, if you want to remain anonymous in a text box somewhere in there, just say, I want to be anonymous, and we're happy to do that. We want to protect you, but we also want to provide you what you need where you are in COVID-19. So we want to be supportive for that. And then one last housekeeping, you'll receive an email, you should have received it in the next couple minutes, for the evaluation for this session. If you need CE, you need to complete that in full, including your license number. That is probably the most important part of that form. We've had a couple forms in the past that did not have license number, so please do that. The evaluation also helps us get better, and we want to grow and improve and, again, serve your needs and make you happy to be part of this community of practice with Project Echo. So if you all would fill that out for me, that would be lovely. And then after you do that, you get a second link for the certificate, and then from that link you just click submit. But as always, if you have any questions or concerns, just please send me an email. The PowerPoint the PowerPoints are always in Box if you need them. They're quite large, so to email them back and forth is a little difficult. So if you all want to use those for, we said, nursing students and everything, feel free to do that as well. And resources and articles are always in Box as well. Again, if you have no idea what I'm talking about, just send me an email and I'm happy to direct you there. So I think that is our time, unfortunately.
I know, so.
But
Right.
thank you all for joining us. We'll see you
Thank you.
next week. Please join us. We only have 3 sessions left, unless I can convince Ruth to do a couple more. Have a great week.
Take care.
Bye.